And here we are again, direct from Roswell Park Cancer Institute in Buffalo, New York, with Cancer Talk Live. I'm Tim Wenger, and this session, we're talking about colorectal cancer and colorectal cancer with specificity toward the direction of high-risk patients. At the end of this session, you'll know exactly what we mean. You'll know who those people are, and you'll know what Roswell Park can do for you or for your loved one who you might be viewing this and thinking about at this time. Throughout the evening, we'll take questions from you live via Twitter. We have a hashtag all set. It's on the screen beside me, and that hashtag is CRC Talk. And over the course of the past several weeks, we've been collecting questions from you, not from me, questions from you about high-risk patients with colorectal cancer or concerns about colorectal cancer. Who will answer the questions tonight? Certainly not me. We've got the panel of experts here from Roswell Park Cancer Institute, and we'll start over here to my right, and that is Dr. Stephen Nurkin. Dr. Nurkin, welcome to our webinar tonight.
Thanks for having me.
Thank you very much. You are a surgical oncologist here at Roswell Park, and you specialize in gastrointestinal and precancerous conditions and cancers of the colon and rectum. Thank you for being here again.
My pleasure.
And by your side, we've got Dr. Nicoleta Voian. Dr. Voian, Director of the Clinical Genetics Service here at Roswell Park, and you help individuals understand their cancer risk based on their personal and family history, and we're going to talk a lot about that tonight, so I really appreciate you being here as well.
Thank you for having me.
And way over here by my side, we've got Dr. Andrew Bain. Dr. Bain, welcome. Chief of Endoscopy and Assistant Professor of Oncology here at Roswell Park, and you work specifically in Roswell's new state-of-the-art endoscopy center, and perhaps we'll find out a little bit about what that state-of-the-art facility is.
Thanks, Tim.
So thank you. Dr. Nurkin, I'd like to start with you. Just some basics, some 101 about colorectal cancer, if you would.
Sure. So colorectal cancer is the fourth most common cancer in adults in the United States. It's the second leading cause of cancer-related deaths. And what probably is the most important, it's one of the most preventable. We know that people can develop some precancerous or changes with the lining of the colon that lead to the formation of polyps or overgrowths. These polyps or overgrowths, we know if left long enough, can potentially turn into cancer. We know from large studies that having these polyps removed can reduce your rate of not just developing cancer, but from dying from cancer over many, many years. So there are a subset of patients that are people that can have a propensity for growing some of these polyps. These people are at or considered at an increased risk of not just polyp formation, but of cancers. And specifically, there are groups that have a high risk or a high propensity for the development of these cancers, such as people with some of the hereditary genetic cancer syndromes. Most of the people that might be viewing tonight and most of the public is really considered average risk. The average risk folks, which make up about 80% of the new colorectal cancer diagnoses, which we call sporadic cancer, new cancer diagnoses, occur in these average risk folks. So these are people that are over the age of 50, no history of polyps, especially adenomatous or precancerous polyps, no family history of cancer or advanced polyps, no medical conditions that can increase the risk of developing colorectal cancer, such as inflammatory bowel disease like ulcerative colitis or Crohn's disease. So if you fall in that population, you really are considered average risk, and usually those guidelines, or screening at least, is at the age of 50. That will change if you are considered more at an increased or high risk for developing colorectal cancer.
A lot of us fall into that average bucket, but a lot of us out there tonight are more concerned, and there are high-risk patients and families of patients that really have some questions. And Dr. Voian, that's why you're here with your specialty in genetics with regard to this specialization that we're talking about tonight. Let's talk a little bit deeper and a little bit more about who is at high risk. What do we need to know there?
So definitely the patients who are referred to our clinic fell in the remaining 20-25%. So beside the sporadic, which is the majority of colorectal cancer, the rest is familial or inherited predisposition for cancer. And the red flags for somebody who is at high risk due to those two, family history or having an inherited predisposition for colorectal cancer, are young age of onset for colorectal cancer, or having adenomatous colon polyps more than 10, having family history of colorectal cancer in multiple family members on the same side of the family, having a family history of colon cancer and other cancers that we know that can be associated with a syndrome like uterine cancer, ovarian cancer, thyroid cancer. These are red flags for somebody who needs to be referred to our clinic. And if appropriate, after reviewing their personal history and family history, we will offer genetic testing to identify if that person carry a mutation that would predispose him or she to an increased risk for colorectal cancer, and to try to establish their risks. And we collaborate with Dr. Nurkin and Dr. Bain because even if they don't carry a mutation, having family history, they need personalized screenings starting earlier, and having the colonoscopy at the interval will be reduced compared with general population risk.
Once that determination is made and someone is determined to be high risk, it all comes down to what kind of diagnostic services are available. And here at Roswell Park, those are great, and those are many. And that's why Dr. Bain is here, or at least part of the reason that you're here tonight. Talk about what happens and what is available to a patient here once we get to the point where, yes, we need to be screened.
So whether you're at high risk for colon cancer or average risk, the gold standard for screening for colon cancer is truly a colonoscopy, which most of you know about. But there are a long list of options, which is good because it can be tailored for you, but it can also be confusing because there's a long list of different things that, different tests that you can get to detect colon cancer. Besides colonoscopy, there's flexible sigmoidoscopy, there's a CAT scan devoted to the colon, or CT colonography. There's tests that detect microscopic amounts of blood in the stool. And there's a few newer tests like a capsule, a pill capsule that you can swallow that images and takes pictures of your colon that are sort of newer and under investigation. So all these things are good, and there's a lot of research and studies going on to determine what is the best. But we'll work through some of these different modalities as the questions come up.
And some of those questions have already come in to roswellpark.org over the course of the past several weeks or so. And we're taking questions live on Twitter too. I just want to keep reminding you of that. Use that hashtag. The hashtag is CRC Talk. It's on the screen over here beside me as well. Hashtag CRC Talk. Some of those questions are already coming in. I want to start with a question, though, that was submitted via the website over the course of the past couple of weeks. Dr. Nurkin, I'll start with you on this. A gentleman writes us and says, as a 54-year-old man in good health with colorectal cancer in close family history, how often should that gentleman be screened?
Yeah, that is an extraordinarily important question. Again, first of all, at 54 years old, if he hasn't gotten a colonoscopy, if you haven't gotten a colonoscopy yet, you should be getting one. So even if you are considered average risk, the recommendations, some of the national recommendations are to start your screening at age 50. It really is important to get a detailed family history whenever somebody is getting risk assessed for colorectal cancer. So the close proximity, it's important, whether it's a first degree relative versus a second degree and others. So really learning about that family history is critical. If it's just one family member, depending on when they were diagnosed, if it's a close family member, even a father or a brother that was diagnosed at age 80, then most likely what's common is common, and that is a sporadic cancer. So this gentleman may very well be an average risk person, but should still start getting his colonoscopies at age 50, so he probably should get one if he hasn't gotten one already. Then to determine how often he needs one really is dependent on what is found at the time of that colonoscopy, whether there are polyps that are found, specifically adenomatous polyps, how many were found at that time. So that'll determine what interval needs to be, or how he needs to be followed after that first initial scope.
All right, and as the questions come in, we'll get to them. And here's another one, Dr. Voian, I'm going to start with you on this one. It is kind of wordy, okay, so get the thinking cap out right now. I've recently been diagnosed with FAP. I'm having my colon and rectum removed in April. What is the likelihood of the polyps spreading beyond the colon after removal? There's more to the question, but we'll start there, and you'll have to cut through the lingo of FAP for us too.
So FAP is the abbreviation from familial adenomatous polyposis, which is an inherited predisposition for colorectal cancer. It's a serious condition. It's an autosomal dominant inheritance mode. So if the patient was diagnosed with familial adenomatous polyposis, I would like to know if he or she was tested and a mutation in the APC gene was identified, or the diagnosis was just made clinically, because if you have a colonoscopy and you have more than 100 colon polyps, a clinical diagnosis can be made. Identifying a APC mutation for the FAP families is very important, because we can test other family members. And as I mentioned previously, having an autosomal dominant inheritance mode means that each of the caller's children will have a 50-50 chance to inherit the condition. We know that persons with FAP would have an increased risk for colorectal cancer, and they will start to develop polyps in their teen years. By age 20s, there will be multiple polyps, and many of them they will have to have colectomy, because the burden of polyps is really very high. And we know there are other extracolonic manifestation of this disease. Sometimes they have polyps in the upper tract, and that's why we recommend colonoscopy and upper scope, at least a baseline, to see if there's any polyps in the stomach or duodenum, because the duodenal cancer is the second cancer for people with familial adenomatous polyposis. And the interval of screenings need to be estimated based on the findings at the colonoscopies or upper GI.
And that viewer was also interested in reading material where they can find information. I always direct people directly to roswellpark.org, and they can certainly call Roswell Park and get information.
Correct. Calling Ask Our PCI, that family can be offered a genetic counseling appointment, because screening for people who have a mutation in the APC gene, so they have familial adenomatous polyposis, should start screening with colonoscopy by age 10 to 15, so very early. And we can provide material appropriate for, a young child or a teenager, specifically written for them.
All right, again, roswellpark.org, a wealth of information on that website. You can always get all you want right from there, and certainly by calling Roswell Park at 877-ASK-RPCI, they certainly can help you and direct you to qualified information, and that's 877-275-7724. Dr. Bain, we're going to go right to some of the live questions that are coming in, and I think this one is directed right at you. Can you discuss the advantages of advanced diagnostics such as endoscopic ultrasound or for colorectal cancers?
Sure. The mainstay of finding polyps in colon cancer is colonoscopy. There's been a lot of advances with the technology for endoscopes that we use to do colonoscopy, and the most scopes that are used nowadays are high definition, and these are very useful for detecting small polyps. And a type of polyp that has been getting a lot of press lately is a flat polyp, and the newer scopes are very good at detecting these flat polyps. Endoscopic ultrasound is another version of an endoscopy where there's an ultrasound probe at the end of the scope. This doesn't have a huge role in colon cancer. It is used for rectal cancer, mainly after rectal cancer has been diagnosed. Endoscopic ultrasound is a good way to stage rectal cancer, to determine how early or how late it is. But for looking at polyps, which are benign growths in the colon, and for staging colon cancer outside of the rectum, it's actually not very useful, but definitely has a use in rectal cancer, but not so much for colon.
All right, this is Cancer Talk Live. We are live from Roswell Park Cancer Institute in Buffalo, New York. We are talking about high-risk colorectal cancer. And the next question, Dr. Nurkin, somewhat vague, but I think an opportunity really for yourself and for anyone else here, Dr. Voian or Dr. Bain, to talk about screening again. And this comes from a female viewer. Should I have additional screenings other than colonoscopy, mammograms, and annual gynecological exams?
Yeah. Well, that is also going to depend on if they do fall into some of the increased risk, high risk, or some of these hereditary conditions, okay? So there are some what we call extracolonic sites, other areas or associated cancers that are related to some of these cancer syndromes that we discussed. So familial adenomatous polyposis, FAP, Lynch syndrome, some of the other known polyposis syndromes have their own associated cancers. So I think one of the benefits of coming to a place like Roswell or someplace similar to Roswell is the focus on a multidisciplinary approach for handling some of these difficult diagnoses and some of these inherited syndromes. Having a team of experts that are involved in those different cancer sites and are familiar with what cancers you are at risk for by having some of these genetic syndromes is critical. I think staying on top of the literature, being familiar with some of the new genetic mutations that are coming out. What's been fascinating to me is some of the questions some of the pre-submitted questions of people coming in really educated on not just their, Lynch syndrome, for example, but what specific mutation that they have, which is important because, in the past, everything was just grouped together as, say, a Lynch syndrome. But now we're learning more and more about what specific mutations are coming in, what specific mutations these individuals have, and then what their associated risks of developing not just colorectal cancer, but other cancers. And we can really tailor their screening and their surveillance depending on their exact mutation. And being on top of this and having really world's experts like Dr. Voian, for example, to kind of oversee some of that and stay on top of literature is critical. And I think that's one of the benefits of coming to a place like Roswell for your high risk screening needs.
And I've seen those questions as they've been coming in over the past couple of weeks, and like you, I'm very impressed with the level of knowledge that people have, which tells me that we've really struck an area of interest out there with regard to high-risk colorectal cancer. Dr. Bain, we're going to jump over to you for this next pre-submitted question off the website prior to the webinar tonight. What kind of screening is required to find out if you're more likely to get colorectal cancer? My mom, my grandmother, both had cancers in this area of the body. My mom just recently passed away from the disease. What else can I do to prevent the disease?
I think the important thing that makes a distinction between average risk and high risk is family history and your personal history. So the more you know about what medical conditions your family has, whether it's colon cancer or whether it's other types of cancers, breast, ovarian, endometrial, that can all play into what risk you are for developing colon cancer. And also your own history. Have you had a colonoscopy in the past? If so, how many polyps were found and what type of polyp they were. That all goes into the formulas that we use to figure out whether you're average risk and you can have your next colonoscopy in 5 or 10 years, or whether you're at higher risk where you might need additional genetic testing or have more closer surveillance.
If you're out there on Twitter, the hashtag again is hashtag CRC Talk, and Dr. Nurkin, you want to jump in on that?
Yeah, it's something else to add because I think the follow-up question was prevention. And there have been a number of questions that have been coming in over the week or so on how can you maybe reduce your risk. For the high-risk groups, some of the inherited syndromes, getting screening and surveillance in some of these groups is, of course, critical. And we can't stress the importance of getting your colonoscopy, getting those polyps removed. Good screening is not just identifying or it's both preventing cancer and catching it early on, right? So again, the focus of getting your screening, increasing awareness for screening, and getting your appropriate screening tests like colonoscopy. With regards to prevention, a lot of the data that's out there is with regards to reducing your risk of developing colorectal cancer is stuff that we try to do every day, these modifiable risk factors. So things that have been known to reduce the risk of developing polyps and also cancers are good, heart healthy, and good living, okay? So stop smoking, introducing get more of those fruits and vegetables, about 5 servings a day of fruits and vegetables every day, reducing, alcohol in moderation, don't overdo it, right? Reducing your red meat intake, processed meats, okay? Physical activity, getting your daily allowance of good physical activity, getting up, getting around, reducing the risk of a sedentary lifestyle and all the complications that come with that. So it's good heart healthy, good common sense, good living, treating your body well, okay? And life is also for enjoyment, so everything in moderation, okay? But those are some of the things that have been associated with maybe colorectal cancer prevention. Some of the new and exciting research that has been out there that I'm starting to mention more and more to patients is maybe getting on aspirin. We know that polyp development and cancer development has some inflammatory component to it. So there's been some emerging data over the past few years and so is by trying to reduce some of that inflammation with some of those medications such as NSAIDs, non-steroidal anti-inflammatory medications, and aspirin, showing reduction in polyp development and also even after being treated for colorectal cancer, showing some good outcomes. So that's some of the newer stuff. There's some other stuff that was just recently presented at ASCO looking at vitamin D and taking that. So with regards to maybe adding aspirin to your daily regimen, maybe vitamin D and other things, I would definitely talk to your primary care physician on seeing if whether or not that would be beneficial for you, not just for cardiovascular health, but also for cancer prevention strategies.
Every 2 months or so, I stand here at Roswell Park and we talk about a different area of expertise, but every time we do it, somehow, some way, the details of diet, exercise, tobacco, and alcohol come up, which really is an important thing to think about because, I mean, like you said, everything in moderation, and it seems to cross all cancers as far as prevention is concerned.
Yeah, many.
All right, Dr. Nurkin, thanks so much for that. The next question that came in via Twitter, I think Dr. Voian, I'll start with you, and I think Dr. Bain might have something to add to it. I have a family history of colon cancer in my mother and sister. Can I be screened at Roswell Park? I think there's probably an easy answer and a longer answer.
So definitely the color is very appropriate for the high-risk colorectal clinic and would be very important to learn how old were the family members when they were diagnosed with colorectal cancer, because it is very important to know your family history, especially the ages when the cancer diagnosis was made, and also were there any polyps during the time when the diagnosis was made. If that caller definitely will start seeing the high-risk colorectal clinic, she or he may be appropriate for genetics, again, based on the ages of diagnosis and maybe the type of colorectal cancer they had.
I'd like to pause for just a moment and ask you this about screening someone for the high risk. We've gone through the parameters and what you look for, but if someone out there is concerned, what do they do? Call?
So they will call the Ask Our PCI, and there is a very good, I would say great team that will triage them, and based on different questions regarding family history, personal history, they will be screened if they're appropriate for high-risk colorectal clinic only for the GI component, or if they are appropriate for genetics also, or if they are appropriate for other high-risk clinics, because we have high-risk breast clinic, we have high-risk GYN clinic, and many times, cancer can run in family in multiple ways. So we have people who are appropriate for high-risk breast clinic and also high-risk colorectal clinic. So it will be very important to call ask our PCI to identify exactly the risks and where that person needs to be seen just by the high-risk clinic or the genetics.
Dr. Bain, I think it's an opportunity for you to jump in and talk about the screening at Roswell Park and the multidisciplinary aspect of colorectal cancer screening that's available here to that person and obviously so many others.
Sure. I think if the patient is identified as being someone who qualifies for high risk, they would get an office visit with Dr. Nurkin and or myself, and we would talk about the risks and go over the various options for screening. And average risk, there are a lot of different options, but with colonoscopy being the gold standard. But for high risk, really, it is important to stress the need for a colonoscopy, because these are patients that are above the average population risk for having polyps and for having colon cancer. So these patients might not be the best patients to get an occult blood stool test or a flexible sigmoidoscopy, because the chances of them having polyps that you need to remove are higher. So they probably should go right to a colonoscopy, which is the gold standard. And colonoscopies are offered at Roswell as well as many excellent places in the community. So I don't think there is a lack of places to get a good quality colonoscopy.
All right, Dr. Nurkin, this question, again, presented, I think, very simply. But I think the answer could maybe be a little bit more complex. I have screening every 3 years. In that time, I grew 5 polyps. Am I a high-risk cancer?
Yeah, so we see these kind of patients all the time. They're just polyp makers. And again, sitting down and having a detailed discussion about do they have some modifiable risk factors that we can correct, like we discussed before? Some of the physical activities, some of the smoking, really encourage some of those changes in lifestyle and getting not just heart healthy but colon healthy. And then, obtaining a family history as well. If there is a family history of colorectal cancer, a lot of polyps that run in your family, if there are some of the associated cancers that, may be sending off alarms that this may be, that there's a reason why you're a polyp maker, then we would try to identify those and then go more in the direction of some possibly genetic testing. A lot of the times, people just like you that have multiple polyps, especially quite frequently, almost every single time a gastroenterologist will go and screen your colon, will identify a polyp. And it is important to ask what kind of polyp it is. There are some little inflammatory polyps that don't maybe have as much as the risk as adenomatous polyps, maybe perhaps a hyperplastic polyp, for example. A single hyperplastic polyp here and there usually does not give you that risk that adenomatous polyps have. So it is important to distinguish what kind of polyps you have, and then try to risk assess you as well to determine if you are just simply a polyp maker that needs to have frequent colonoscopies, or if you're really in that high-risk group for developing colorectal cancer and potentially other cancers as well.
Dr. Bain, I think I just want to jump over to you a little bit, because the so-called polyp maker, is determined and identified by you and your team and elsewhere in the community. Need I be overly concerned if I'm simply a polyp maker?
I don't think you need to be overly concerned. I think the most important thing is that you've been identified as a polyp maker because you've had your screening colonoscopy, and if you continue to follow your gastroenterologist recommendations about when you should have your next one, whether it's 3 years or 5 years, the beauty of a colonoscopy is you're finding these polyps, but you're also removing them, and the more polyps you remove, the less there are in your colon that could potentially turn into cancer. So I wouldn't be overly concerned, but it should give you the right amount of worry to remind yourself that, oh, I need to get in to have my next colonoscopy in the recommended timeline.
It's Cancer Talk Live from Roswell Park Cancer Institute here in Buffalo, New York, as we continue our discussion about high-risk colorectal cancer. And the conversation continues with you out there online with Twitter, hashtag CRC Talk, as the questions continue to come in. Feel free to do so, and they are coming in. And our next one is going to go over to Dr. Voian. We've got Dr. Bain, Dr. Nurkin here at Roswell Park to answer your questions throughout our webinar here live from Roswell Park. Dr. Voian. Here's the question. My father passed away from colon cancer at age 59. He was adopted, therefore there's no family history behind him. I am 30 years old. When should I begin screening?
So this is a special situation. What we also offer here at Roswell Park Cancer Institute is every patient who was diagnosed with colorectal cancer during the time of the surgery, they are doing a screening for Lynch syndrome. So they're looking at a tumor and they offer MSI-IHC, which is the microcellular instability, and immunohistochemistry. They look for some protein and some abnormalities in the colon tumor to screen if there's any abnormality there that would trigger further genetic testing. So I'm not sure if the father of our caller had that done or if not, because it is not implemented in all facilities, but we are doing this universally. So regardless of the age of diagnosis of the colon cancer, we are offering MSI-IHC to screen for Lynch syndrome. Now, the age of over 50 in genetics, we consider a young age, under 50, so over 50 would make probably and closer to the general population risk. But in the case of the caller, having a first-degree relative with colon cancer, he would have an increased risk based on the family history. And we would recommend to have an assessment, a GI assessment, usually at age 40, to discuss the timing of the colonoscopy. And definitely the interval would be adapted based on the family history and also on the finding of the baseline colonoscopy.
You make a lot of people happy and a lot of people sad when you say 50 is the determiner of old.
Well, I didn't establish this cutoff, and that's why colonoscopy for general population will start at average risk will start at age 50. That was the determination made that this will be the age when people will have the increased risk and the number of polyps identifiable will be an increased risk, a number and risk. So the age 50, it's the usually cutoff.
Dr. Nurkin?
Yeah, I think we also need to hit on some of the emerging data that's been coming out over the past year or so. And some of our audience maybe have seen this on some of the news broadcasts. There's been some database reviews, some population database reviews, finding that the incidence of colorectal cancer is rising in early onset, meaning younger than the age 50. And some of these are quite alarming, some of the rates that are increasing. And it's estimated that we may be even seeing a rise of in colon cancer over the next, say, 15 years of 90%, and of rectal cancer maybe even as high as 120%. And it's not entirely clear why this is. It's clearly not all related to some of these inherited cancer syndromes. Some of the concern, or at least the presumption, is due to some of these modifiable risk factors that we discussed earlier, such as the sedentary lifestyle, the lack of exercise, the diets, those processed meats and other things, obviously smoking and alcohol use. But it might not just be that. We're not entirely clear as to why this is happening. So what I think we really need to do, and we should take this moment to kind of not just educate our public, but also our primary care physicians and gastroenterologists and others to kind of be aware that that some of the younger patients that are coming in to see us that may have some of these symptoms that you just would push off to, say, hemorrhoids or other things like, bleeding in your stool, crampy abdominal pain, unexplained weight loss, things like that really should start sending a lot. It's really some of these symptoms that just aren't going away should prompt some more investigation, because the last thing that we want is just some of this younger group that you really don't identify any obvious risk factors or putting them in a high risk group that may go unchecked and end up coming in at a later stage. So I think it is important to be aware of some of this early onset colorectal cancer, and even know that some of the national societies are starting to talk about even going a little earlier in surveillance and starting the screening. There are clearly some other increased risk groups. We hit on some of those before, such as inflammatory bowel disease. Also, African Americans are at an increased risk for developing colorectal cancer, and some societies are really encouraging and to start screening in this population group even at age 45. So it is important to go out there. It is important to talk to your primary care docs. And if some of those symptoms just aren't going away, getting better, and are really unexplained, get checked.
It's always a key when something is persistent and does not go away. I hear that a lot.
Yeah.
Okay. You've brought up, it's interesting to me, and I think interesting to a lot of the people out there that are joining us tonight, diet. You've brought it up several times, and we had a specific question about it. What is the best diet for colon cancer prevention? And they mentioned gluten-free. They mentioned low carb. Is there a diet that people should be concerned about, and is it for everybody, or is it for those who we've identified as high risk?
Yeah. So again, we hit on some of those a little bit before. There's some research, some small series looking at some different things that you can, add to your diet. Whether it's, we do know that, good, like I said earlier, heart healthy eating, fruits and vegetables as being one of the major components of your diet, as being critical, as being important as well. Red meats, trying to avoid it, again, in moderation here and there, but trying to avoid it as some of the major staples in your diet. A higher fiber diet has been associated with reducing, maybe rates of colorectal cancer, and it's hard to say there, but these are some of the things that keep coming up over and over again of ways of kind of preventing some of the colorectal cancer risk.
I suspect our post-webinar dinner is going to be kind of boring tonight.
Yeah,
right?
yeah, exactly.
Okay.
Salads for everybody.
Dr. Bain, this one came in. I wasn't going to bring it up, but someone did. So here we go. They're using that hashtag out there, CRC Talk. If you're out on Twitter, feel free to do so, and we'll try to get to these questions as we continue along through our web discussion here from Roswell Park Cancer Institute. What can I expect from my colonoscopy prep? It's the $50 million question that everybody wants to know.
Yeah, I think the most common thing you can expect is that it's not going to be pleasant. It's sort of the dreaded part of the colonoscopy. In fact, most people say that after the prep, the actual procedure is really not a problem at all. Most people fall asleep during the procedure with sedation and wake up afterwards and remember very little of it. But unfortunately, the prep is a necessary part of not only colonoscopy, but a lot of other different colon cancer screening tests. So some people will say, well, I don't like the prep, I'm going to get a CT colonography. Well, that requires a prep too. Newer capsule colonography where you swallow a capsule and it takes pictures, it sounds great too, but that also requires a prep. So unfortunately, there's no real way to get around doing the prep. And I think the important part is really to devote time and effort into doing the prep, because the better your prep is, the better your gastroenterologist can see while they're doing your colonoscopy. So let's say your prep is fair, you may miss some small polyps, and your gastroenterologist may not feel confident enough to say that you're good for 10 years and do your next one in 10 years. If your prep is very, very good and your gastroenterologist is very sure that they saw every corner of the colon, you might be good for 10 years. So it's worth putting in the extra effort. It's not going to be pleasant. There are a number of different formulations. large volume of liquid, half of the volume, there's Miralax, there's Go Lightly, there's a lot of different pills, there's a bunch of different preps. Some are more tolerable than others, some do a better job than others, and there's a lot of options. So, you know, if you have a lot of questions about your prep prior to a colonoscopy, that would probably be worth seeing your gastroenterologist in the office and you know, talking about your concerns. And if you've had a colonoscopy in the past and the prep didn't go well, that would be good to bring that up so that they can change the type of prep used so that you can get the best colonoscopy possible.
There are people all over Roswell Park. It's a big campus. Is someone working on getting rid of prep? Is someone working on that? I'm kidding. I'm
yeah,
kidding.
they
Of
should
course
be.
we can.
Yeah.
I'm going to pepper you with some questions here. It's the lightning round, so to speak.
Sure,
You brought up a couple of things there that came in on our pre-submitted questions. How effective are mail-in colorectal screening tests? I've never heard of such things.
Yeah, so these are tests, and it depends on the type. There's a number of different types of these mail-in tests, and what they're doing is they're detecting trace amounts of blood in the stool. These are good because they're readily available, they're fairly cheap, and they're easy to do. You don't have to take a prep for this type of screening. They're good for average risk patients, but probably not so good for high risk patients where you have a pretty high likelihood of finding polyps. The downside of these is, you know, if you think of screening for colon cancer, there's tests that look for polyps that you can remove and potentially prevent a cancer from forming. And then there are tests that look for the presence of colon cancer. The best screening test will detect polyps, which are precursors to colon cancer, so you can intervene on those and prevent someone from getting cancer. These tests that detect blood in the stool, those are detecting blood that's coming from a colon cancer or a very large polyp. So, you know, these are better than doing nothing, but the gold standard really remains doing a colonoscopy because this is the test that finds small polyps that you can remove and prevent cancer from forming in the future. But, you know, if this is what's available, you know, doing this is absolutely better than nothing.
We've covered it pretty completely, but two other people have submitted a question regarding the pill colonoscopy and the virtual colonoscopy. Maybe briefly touch on each of those.
Sure. Virtual colonoscopy has been around a little bit longer, and this is included as an option in a lot of the different society guidelines. So this is a non-invasive way of screening for colon cancer. Again, it fits more into average risk rather than high risk. It's a CAT scan that you get to look for polyps in the colon. It's pretty good at detecting colon cancer or large masses and even large polyps, but it can miss smaller polyps, especially those flat polyps, which just won't show up on a CAT scan. It also requires a prep, so don't think that I'm going to get the CAT scan and avoid the prep, because you'll need a prep for that too. And if you do see polyps on a CT colonography, you're probably going to have to get another prep to have a colonoscopy to get them removed, so that's sort of the downside of that. The capsule endoscopy that looks at the colon is a newer technology. We use capsule endoscopy often to image the small bowel, but there's a variation of that technology that allows you to look at the colon as well. And this is sort of under investigation, and not a lot of the societies are currently recommending widespread use of this until it's been further tested. But it's an interesting technology, and we'll have to keep an eye on it.
Dr. Nurkin, some thoughts on those procedures?
Oh yeah, and you know, it wasn't at that person's question, but I think there was another one that was written in or submitted a week or so ago, just with regards to also some of the new things that are still coming out, we're learning about, such as Cologuard, which is testing actually the DNA within the stool. So it's a fecal test similar to what Dr. Bain was mentioning before, as well as a blood test that's available. That, you know, there may be some things that are released into the bloodstream. This Colovantage, somebody wrote in about that question. Again, these are not in the formal guidelines of what Dr. Bain was mentioning, and we're learning a little bit more and more about them. They do a pretty good job at detecting some advanced polyps and maybe some cancers, but there's a high false positive rate, meaning it's just, you know, it was incorrect. And really, a lot of times if it comes back as being either faulty or unclear, or, you know, is coming back abnormal, you're going to need your colonoscopy anyway. So there were some pre-submitted questions. Again, all of us would agree that any screening is better than none, but just to reiterate also that colonoscopy is probably your best bet.
Genetic testing, Dr. Voian, we've talked a little bit about it tonight, and one of our webinar viewers out there is wondering, is genetic testing covered by insurance?
If it's appropriate, majority of insurance carrier will cover the genetic testing, and for every patient that we are seeing in our clinic, we ask them to check with their insurance if the consult is covered. But if they are appropriate for testing, that will be our job. So we will work on the pre-authorization, and the patient shouldn't be worried that they will end up with thousands of dollars. They will know ahead of time before the test will start if the test is covered or not. And as I mentioned, the majority of the insurances will cover if it is appropriate and if there are definitely some criteria are met.
From roswellpark.org, as we've been collecting these questions over the past several weeks, we've had some very specific ones come in, and I think, Dr. Voian, I can direct this one at you. I've completed my chemo for colorectal cancer, and since my mother passed from ovarian cancer, I did genetic testing to see if I was at high risk for other cancers. The result of the genetic test said I had the gene MSH6, uncertain clinical significance. What does that mean?
So I would assume that this person was identified with a variant of unknown significance. And when we meet with our patients, we discuss the possible results that every genetic test can have. And the first one is positive when a mutation is identified, which means an alteration of the gene is identified. Therefore, that patient is at increased risk to develop certain types of cancers. A negative result means it depends if there is a mutation known in the family or if it's not known in the family. If the mutation is known in the family, having a negative result, it's usually good news. That patient shouldn't be worried about the risks associated with that specific mutation that runs in the family. But if there is not known of mutation in the family, we call a negative result a non-informative. So this means that we still do not know, and that patient needs to follow screening based on the family history or personal history. Now, the third possible result is called a variant of unknown significance. This means that the laboratory identifies a change in the DNA of the gene, but they cannot tell for sure is that a harmful or a benign change. Therefore, they call it a variant of unknown significance. Medical management should not be based on that variant of unknown significance because, again, we do not know what this means, and no clinical testing for other family members should be offered. Now, this patient, MSH2 gene is a gene associated with Lynch syndrome, and appropriately this patient was tested for Lynch because she or he had colorectal and the mother had ovarian cancer. But I want to mention and to make aware the color because he or she needs to be tested also for BRCA1 and BRCA2 because everybody who has a first or second degree relative with ovarian cancer, BRCA1 and BRCA2 should be also tested. So we encourage the caller to have a consultation with us to make sure that the appropriate genetic testing was performed, or if she or he needs further testing, we can offer that.
Next question regarding screening came in before our webinar tonight. Dr. Bain, this one for you. Fecal occult blood screening, FOB, is being increasingly promoted in our area as the preferred screening tool for those with an average risk. I have a two-part question related to this. What does average risk mean? And can you discuss the merits and shortcomings of FOB?
Sure. Average risk, like we discussed before, is there's no strong family history of colon cancer. It's someone that has turned of age where they're at risk for colon cancer, which is 45 if you're an African American or 50 if you're not. So that's really what average risk is. There's no family history of colon cancer or any other types of cancers where you would think of one of these genetic syndromes. And what was the other question?
Just related to the average risk, and then their second follow-up was, the merits and shortcomings of that test.
So these are tests that detect blood in the stool, and like I said before, these are easy and they're cheap and they're widely available. They're good at detecting cancers and very large polyps, but they're not very good at finding small polyps. So if this is something that's readily available in your area and colonoscopy may not be, this is, you know, absolutely an acceptable screening test for you being average risk. But if you're at higher risk, or if, you know, doing a colonoscopy is an option, I would recommend doing the colonoscopy because it does have a lot of benefits over the blood testing kits.
Dr. Nurkin, at the beginning, I know we did address some general issues regarding colorectal cancer, but our next live question that came in from Twitter and our hashtag tonight, are there symptoms to watch for with colorectal cancer? It's a simple question, but it really is on the minds, you know, what do we watch for? What should we be aware of?
Yeah. So often, and that's why we've been hitting on screening and starting your screening early, so to try to identify or prevent these cancers before they even come up, right? But once they do, there are some recurring symptoms that may often not resolve. And what was mentioned before was, you know, blood in your stool. Unexplained, so not like a hemorrhoid that you're suffering from that doesn't go away. This is a, you know, ongoing bleeding kind of in your stool that you see either on your paper or dark stools. Okay, that's one. Two, kind of recurring crampy, maybe abdominal pain. Some unexplained symptoms like unexplained weight loss, maybe loss of appetite, that's also unexplained. Unexplained anemia in people over the age, especially over the age of 50. These are some of the recurring symptoms that some folks experience with a new diagnosis. Sometimes if the tumor gets large enough, that crampy abdominal pain, more of distension, people may be suffering from. You know, and again, that goes with some of that feeling of feeling full, bloating, maybe even vomiting, and others. But if you really start to develop, decreased maybe even caliber of your stool, so you go from having normal, regular, everyday stools to starting to become more and more constipated. That is definitely a frequent symptom that people present with. This unexplained, I don't know why, I just assumed it was related to my diet, or, you know, I was just more constipated, but a change in the caliber of the stool, the frequency of their stools, those are some of the things that you look for.
We hear the phrases tossed around quite a bit with regard to cancer as far as slow growing, fast growing cancers. And this viewer writes this question to us: is colon cancer slow growing, and is it okay to leave a portion of the polyp but monitor it? It sounds like they underwent a procedure and are asking that specific question.
Yeah, and maybe Andy can chime in also. More and more we are advancing some of our endoscopic techniques. There are some endoscopic techniques that are becoming more and more available, such as endoscopic mucosal resection or endoscopic submucosal dissection. And what that allows for are removal in the entirety of polyps, to remove it all, often at just one shot. In the past, people that had large polyps went straight to surgery, but there are more advancing techniques that we can use, such as these endoscopic resection techniques that allow for removal of some of these larger benign polyps, not, you know, truly really, you know, large cancers or anything, but just some of these larger polyps that in the past weren't able to be removed can now be removed with some of these techniques. There are some times that gastroenterologists would be able to go, or endoscopists would be able to go in and get a couple shots at removing the polyp in its entirety, okay? And it does sometimes take a couple of rounds of endoscopic management to be able to remove these benign polyps in their entirety. So sometimes you can get a couple of colonoscopies to be able to do that, but if you get to the point of where every time you go in there and you continue to have this recurrent polyp that's not going away, sometimes those people are referred to surgeons to have that section of colon removed.
Dr. Bain, any thoughts on that?
Yeah, I think the beginning question of is colon cancer a slow growing? In the majority of patients, colon cancer starts as a very small polyp, and that's the precursor of colon cancer, and it takes many, many years for that polyp to get bigger and eventually it undergoes some sort of a change and develops into a cancer. And we think that that takes several years, maybe up to 10 years, for a polyp to turn into a cancer. And that's why we say if you're at average risk and you've had a colonoscopy with a great prep, you're good for 10 years, because even if the day after your colonoscopy you start growing a polyp, it's going to take more than 10 years for that to grow into a cancer. So polyps usually, cancer usually forms in a very predictable way, where there's a polyp, it gets bigger very slowly and then turns into a cancer. So I think if there is a small part of a polyp that's been left in place and it's a benign polyp, it might not be unreasonable to bring you back and do a colonoscopy in 6 months or a year to try to remove the rest of it. You don't want to forget about that, because as long as there is part of a polyp left inside your colon, that could always undergo change and grow slowly and turn into a cancer. But polyps usually grow very slowly, and so I think in a year's worth of time, depending on the polyp features and the size of it, I think you probably have to go with your gastroenterologist's recommendation, but that's not unheard of.
And while we're over here, a couple more quick hits for you that have come in here. How accurate is the Colovantage blood test as a screening for colon cancer? And then also we have another viewer writing about how accurate is the genetic blood stool fit test?
So the one that most of the guidelines are recommending, because it's cheap and accurate and readily available, is the FIT test. And this is one of the tests that detects microscopic blood in the stool. And these are pretty accurate. They're upwards of 80 to 90% sensitive and specific. So that means they do a pretty good job at detecting blood in your stool. And unlike older tests, they're better at detecting human blood. So if you eat a hamburger the night before, these are less likely to show blood that isn't truly from your body or from a polyp or for cancer. And certain dietary things and vitamins are less likely to give you a false positive with this test. So it is fairly accurate. But again, these are tests that are meant to detect cancer or very large polyps. They're not necessarily screening tests that prevent cancer from forming.
All right, Dr. Voian, this one for you. My family has a pattern of who is affected and who is not. Have you seen other families with patterns? And in my family, it seems to be 2 out of every 3 per generation. Is this a common question?
Definitely what we see in our clinic are people at high risk, and having multiple family members that span in different generations is a red flag. And what the caller mentioned, having 2 out of 3 or in every generation, raise a flag of a possible dominant, autosomal dominant condition. So definitely is very appropriate to be seen in genetics clinic, and also to have assessment, a colonoscopy, as having a family history.
All right, and we just had another question come in on our Twitter feed here, and this basically is: a woman has Lynch. What other screenings and preventative tests are encouraged? I'm not sure who we're gonna.
So Lynch syndrome is one of the most common genetic syndromes that predispose for colorectal cancer, and we'll see Lynch syndrome in about 2 to 3% of all colorectal cancers. People who have Lynch syndrome, they have an increased risk to develop colorectal cancer. Women with Lynch also have an increased risk to develop endometrial cancer, ovarian cancer, and men and women have also increased risk for stomach cancer, small bowel cancer, urinary tract cancer, and other cancers. So for this lady who called and has Lynch syndrome, definitely colonoscopy would be absolutely recommended, and it usually starts in the 20s. It depends on the gene, because there are like 5 genes associated with Lynch syndrome, but screenings with colonoscopy usually starts in their 20s. Also for women, the risk for uterine cancer and ovarian cancer should be mentioned, and there are no clear guidelines in regards of the screenings, because uterine screening with uterine sampling is, it can be offered, but it's not very well known the efficiency of this, and after the woman is done with childbearing, so after 35, 40, she can consider to have a salpingo-oophorectomy, so removing the uterus and ovaries to reduce or for the uterus to remove the risk for uterine cancer and ovarian cancer.
Dr. Bain, a last quick question just came in off of our Twitter feed as we continue here live from Roswell Park. Can a colonoscopy miss a polyp or a cancer?
It can. It's not a perfect test. It's the best we have, but it's very possible that a polyp can be missed. A big part of that is the prep. So if the prep is not a great prep where you're able to see every corner and around every turn, you can absolutely miss a polyp. But even with a great prep, there is a miss rate for colonoscopy, and not every polyp is shaped like a mushroom where it's a big obvious polyp in the colon. Some are very subtle and flat, and so it's very important to look very carefully and have up-to-date technology and endoscopes with high definition and all the bells and whistles on it to really detect these subtle polyps. But it is possible to miss a polyp, but this is the best test that we have right now.
All right, that's Dr. Andy Bain, Chief of Endoscopy and an Assistant Professor of Oncology here at Roswell Park. Thank you for being here tonight.
Thanks for having me.
I appreciate the time. Dr. Steve Nurkin, Surgical Oncologist, thanks for being here. And some parting words for you. What's important for people to walk away from our webinar tonight with?
I think we hit on some of the major factors and heart healthy, good colon healthy living, okay? And we know what some of the modifiable risk factors are, not for just reducing colorectal cancer, but of course other cancers, and get your screening. Get your screening.
All right, and Dr. Nicoleta Voian, Director of the Clinical Genetics Service here at Roswell Park, thank you for the great insight tonight, and any parting thoughts for our viewers out there?
Yes, and I want to complete the answer that I previously gave. So people with Lynch syndrome, people with familial adenomatous polyposis, people with other hereditary cancer syndrome that predispose to colon cancer and other cancers, the best way to have care would be in a multidisciplinary clinic, because having colonoscopies and having GYN screenings and having upper scopes and having thyroid screenings under the same roof, it's very easy. It makes sure that you didn't miss any of those screenings, and also will mention to you, is there anything new in the guidelines in regards of the screening? Is there anything new in regards of genetic testing? Because the testing that we offered 10 years ago for Lynch syndrome covered only 2 or 3 genes. Now we have 5 genes. We have better tests. So that's why a multidisciplinary clinic is essential.
Dr. Voian, thank you so much. Dr. Nurkin, Dr. Bain, just 3 of the incredible resources here at Roswell Park. There are so many more, and we'll continue our webinar discussions here live from Roswell Park. If you have any questions at any time, you can always call Roswell Park. It's a toll-free line at 877-ASK-RPCI. That's 877-275-7724. This webinar will be available at roswellpark.org. Thank you so much for joining us, and we'll be back soon.